Hello everyone and welcome to the Lisa Burke Show. It is always a great pleasure to have you on board watching the show on RTL Play, or perhaps you're listening on Today Radio or Apple Podcasts or Spotify. Whatever way you're finding us, we're just grateful that you're part of this community. Now today I've got two wonderful guests, of course. They're always wonderful guests, and we're going to talk about healthcare and a taboo topic, but we're going to try to make it less taboo. So we're going to talk about pain, education, empathy within the healthcare system, incontinence and postpartum experiences. And my two guests are Sarah Elmquist and also Dr. India Pinker. So welcome to both of you. Thank you so much for coming to the studio and going to share your experiences with us. So Sarah, just to introduce you a little bit, you're a physiotherapist currently working in a private practice with a focus on functional pelvic floor re-education, postpartum and incontinence physiotherapy. So it's wonderful that you reached out about this topic that I know you're making it your mission in life to take away the taboo around this topic. And Dr. India Pinker, you're a postdoctoral researcher based here in Luxembourg at the Institute of Health in a unit focused on aging, cancer and health inequalities. A chartered psychologist by background and now working full-time in research focused primarily on healthcare communication. So again, welcome to you. Now, Sarah, you were the one who reached out to me really because you listen to the show and you know that I'm very happy to talk about topics that are slightly outside the main form of conversation. And one of those is incontinence and postpartum. I mean, let's start with that really, because not everybody even knows what postpartum means. So let's go very basic.
So I think postpartum is a broad topic. Postpartum, what does that mean? Is everything that comes after birth. So we know postpartum in the sentence of postpartum depression, which I will not talk too much about here because I think that goes more into my psychology peers. So we have postpartum dysfunctions in the pelvic floor. We have everything. It's just everything that happens after giving birth. There's so much that happens to the female body in those 9 months of carrying a child in you before it, and then also giving birth, which is a whole process over some too many hours, depending from woman to woman. And again, that too, it's everybody is different and every body is different. So postpartum, some women will have, let's say, some women will have erectus diastase, which is the parting of the rectus femoris. Sorry, that's a different muscle. Of the rectus abdominis muscles, let's say our six-pack muscles, that are intercepted by this line, this fascial line going down in the center of our stomach, and that widens during pregnancy to give space for the growing child. But since it is a passive structure, it's also difficult to re-educate that, and that's what you see, like our bodies change so drastically after giving birth. And again, some women have maybe less a problem with that, but then have a bigger problem with the pelvic floor. You have the
through the act of a natural childbirth.
Through the childbirth, you have the organs, the descensus of the organs, which is also a whole other topic, which is a different approach again than in physiotherapy. You have the later on the incontinence that happens due to insufficient care postpartum, again, after this birthing process, after the pregnancy process.
Well, you're absolutely right. And I know it, of course, varies country to country and what healthcare you happen to be lucky enough to fall under.
Yeah.
And the community around you, your family, who talks to you about these things. And there's still, in my opinion, my daughters are quite old, there was almost no talk about after. It was all before, what happens in the lead up to a birth having the child, having a healthy child, hopefully, and then more or less you just get on with it.
More or less you just get on with it. And I am sorry, you just carried a child for 9 months. You just went through the painstaking process of birthing a child out of this birthing canal that is almost way too small because we're standing upright people. So our entire physiology has also changed to accommodate for standing up. So we're like, there's a lot of action happening there. And then 2 days later, maybe a week later, you can go back to jobs. You can go back to household chores. You can go back to, without the care, without considering that there might actually be a lot of tension still there. There might be a lot of insufficiency in your pelvic floor muscles after that. And I think it's really, really important to just go in and maybe actually have a conversation about this and say, look, your pelvic floor muscles, even if there's not a problem with that, and it's not every woman who is going to develop incontinence later on in life, but why not just go in and at least strategically build up some muscles again, build up the perception of those muscles.
Well, yeah, and I think what you're landing on here is something that is in the future. A lot of people go to the doctor when there's a problem now.
Yeah.
This is a problem right now. And this is kind of a long-term insurance policy, really. I mean, building up your muscles. I mean, we could say the same about our skeletal framework, about avoiding osteoporosis and all of these things that we begin to face as we are lucky enough to age.
Yeah.
So when it comes to the muscles of the pelvic floor, we don't talk about it a lot, actually. And so how does this differ? I know there's obvious differences, but between men and women also, because men have different issues.
So of course, the obvious one is the structure.
Yeah.
We have 3 holes, let's say, very scientifically spoken, whereas men only have 2. Also, the men have the prostate, which is an extra insurance. We don't have that. We don't have that because something big needs to push through, which we wouldn't be able to do if there was something blocking that exit. So we just have more instability already from the get-go. In our pelvic floor than men do. So for us women, incontinence is something, it happens a lot more frequently.
How frequent is it actually? Have we got any statistics on this?
We do.
And from what age is it a problem?
We do, and it's usually the problem starts later on in life.
50s, 60s?
50s, 60s. Let's say, statistically speaking, because that's when, again, the elderly start going to the doctor and the doctor says you have an incontinence. But there's also such a huge dark number because it's not talked about. It's, let's say, the stress incontinence. It's I need to lift the heavy bags and I can feel a drop leaving, which is already not what's supposed to happen. I'm sorry, that's already a dysfunction. It's I want to go play on the trampoline with my kids, but I can't because I know something will come out. That's already a dysfunction. That's already that uncertainty, and that's something that is not talked about a lot. Or again, with the what leaning on to what we said before, it's the this normalization of, oh, you can just go about your day again. It's that's almost normal part of motherhood. It's but it happens to me as well. It's just how it is. It doesn't have to be. It doesn't have to be.
Mm-hmm. And we're leaning into this as though it is something as a consequence of childbirth because of the trauma of natural vaginal childbirth. But how common is it in women in general as we age? For those who haven't had children, is it more common in women who've had children?
Yes. I cannot tell you the exact statistics right now, I'm afraid, but it is more common in women after childbirth, again, because you just have that stressed or like that insufficiency in your pelvic floor that has never been, for many women, has not been retrained. And that's also where we are very lucky here in Luxembourg. You see a lot of women after childbirth come in a few months after to the physiotherapist with a re-education prescription, where they haven't necessarily developed any problems, where they did not have any traumatic birth or anything, but where the doctor says, just as like, again, as the insurance for the future, just do it, and we can already with that help a lot of women, and again also break that taboo topic of.
And so for those who never got that, who were not lucky enough to get that prescription, and they do have a problem, as you're saying, lifting a heavy bag or being worried about joining their children on a trampoline, is it too late?
No.
Or things can be reversed? Things
can be reversed. It's just like, let's say you have an atrophying leg muscle because you've been, you had it broken or something. You can always retrain it. And the same goes for the pelvic floor. You can always train it again.
And then let's talk about the embarrassment factor, because as you said, when I was trying to dig out some statistics, we don't really have the statistics. I mean, that is actually the point. And the point there is people don't talk about it. Yeah. It is a taboo topic. And so how do people feel when they show up? Are they embarrassed?
I actually have not had that many elderly people with those incontinence problems yet. I have, for the moment, dealt with more with the women postpartum. I have also dealt with women who have bigger children, and where the conversation has gone into that topic, and then suddenly there is that, oh yeah, I do actually have an incontinence, or because I talk about that. I talk about that with my patients as well, especially with my women patients. And there's suddenly this, oh yeah, so by the way, I actually do have that losing of a job, or not wanting to play with my children. And that's young women in their 30s, 40s as well.
I think there's a lot of women who don't even view it, as you've just pointed out with that little conversation snippet, as a problem. They don't know that it's a problem. They don't know that it's a sign of something potentially worse to come down the line. Yeah. And in no physical education class that I ever had as a child was this spoken about. We don't often talk about our interior muscles, in different parts of us. It's more the things that we can see on the outside. They're the kinds of muscles that are mostly spoken about in physical education classes. The ones that make you look toned and make you look good. But that one is slightly invisible to many of us. We know where to reach out, and we're trying to lessen the taboo, to open the conversation. And when it comes to conversation, that is exactly what you want to try to do as well, and to bring more empathy into care quality. It's highly connected to recovery. It's highly connected to the way in which the doctors, the nurses have been medically educated themselves as well. And your background, you're also a chartered psychologist with the British Psychological Association. You studied at St Andrews, University of St Andrews in Scotland, on empathy in medicine, and specifically how it can be integrated in communication skills. So a lot of people think communication, it's so soft, it's meaningless, it doesn't have an effect. But when I was reading about your work, it reminded me of the wonderful studies they did on literally just putting some green plants in a bedroom of a patient, or for green to be seen outside the window of a hospital room. In the same way, empathetic communication skills can actually improve a person's health results and, of course, de-stress their situation.
Yes, exactly. Empathy is one of those multifaceted human things that make more of a difference than we realize. And I think it goes back to our nature of human beings looking for that connection, and particularly in times of being incredibly vulnerable, as we usually are in healthcare settings. And I really like the analogy of a plant, that kind of natural part of it. Empathy is arguably one of our most natural sort of elements of conversation, elements of connection as human beings. However, it's almost seen as it's highly controversial, believe it or not, in medicine itself, because there's, as an element of emotion and conversation, as you say, soft, I think the remit of medicine struggles with the hard science, which is incredibly necessary for all of the progress we've made with treatment, but also the human side of it. At the end of the day, one patient is not just the disease on its own. They are within a larger context of being a human being, and that will ultimately change how they navigate their healthcare as well. And it's something we need to consider in wider medical consults.
I know that you deal a lot with oncology and with cancer, for example. And from a doctor's perspective then, how could they empathically tell a patient who's awaiting results of a biopsy, how can they do that as best as is possible? Or should that change also patient to patient? Should they already have an analysis of who the patient is and what kind of information they can receive?
Well, you've hit the nail on the head there a bit. Empathy doesn't have just one face, and I think it's quite hard to say, in an already overburdened system, already high levels of caseload, high levels of stress for doctors who are doing their best. It's hard to say, well, you need to have more empathy, because that's a very generic thing. It's hard to act on. And also empathy itself, just as conversation, is incredibly nuanced and person dependent. So exactly as you say, there is a kind of way of reading the room. When we look at the research, or the research that I did during my PhD, there were elements of authentic empathy being flexible and adaptable to the situation that you're in at the time. It's being able to take the patient as a whole, their context, their day-to-day life, and to use that to adapt your conversation and your behavior as it goes on. Ideally, there are also cases where you can't just bomb drop. I don't think that's ever really the best case. For some, yes, you want direct communication, but it's usually, for example, done in person where possible. And so you can read the response to the information and adjust as you go.
Another thing that you touched upon is that a lot of doctors or nurses, anybody working in the medical profession, they're under huge time constraints, particularly, I mean, in Luxembourg, we're quite lucky. We have generally a fair number of minutes with a doctor here. It isn't the same in other countries, so they have to be quite direct, and they have to use those 7 minutes, for instance, very effectively. How can you be empathetic, deliver the information, and then sit with a patient when they might need reassurance? They really might need reassurance.
Yes, it's a huge debate, but we've recently seen there are some groups working on this, I believe in the UK, that have seen that empathy doesn't necessarily take more time. It's just how you breach the subject and how you create space and safety to ask questions. When there is a sense of safety to ask questions or build the conversation, or at least signposting to, look, I know that this is not enough time to process what I've just told you. However, this is some information you can return to. These are contacts. It's essentially allowing action at a point when they are ready. And in a way, I like to see preparation as a form of empathy. When you've read through the patient case file, when you're looking at the person in front of you and seeing, okay, this is maybe not the time to unburden more, burden them with more information, at least provide some alternatives where they could potentially come back to. And I recognize, systems are not always built to support this, which is a bigger problem that we probably have to address in another way. But I think there are ways of just holding that connection a bit more. I think what needs to be made more obvious is that the effort of human connection goes much further than people realize.
And in your work as well, in your research, have you seen how communication skills when it comes to empathetic speaking and also listening, because as you said, it goes both ways. It's a dialogue of speaking and listening in a circular format. Can it increase beneficial outcomes?
Yes, hugely. There is a growing evidence base of the impact of empathy on patient outcomes, but also healthcare professional outcomes, interestingly. We see higher levels of diagnostic accuracy. We see improved patient concordance, so patients being able to follow advice more stringently. We also see re-engagement with the healthcare system, so they feel it's safe to re-engage with healthcare and health behaviours because they feel they can trust the advice that was given. Someone really cares enough to give them that sort of advice. But also with the healthcare professionals, we see counterintuitively correlations with lower levels of burnout when there's higher presentations of empathy, which again is a source of debate. But that's
Burnout within the medical staff.
Yes, exactly.
Which is very interesting.
Yes.
When you said the burnout, that word, I mean, I was also thinking about caregivers, because I work with a charity involved with this, with rare disease and chronic incurable disease, and burnout rates for caregivers can be very high as well. So again, when it comes to empathetically talking to patients, some patients have to deal with their own sicknesses on their own, really on their own. And so how does the communication change if you're dealing one-to-one with that sort of patient compared to if you're dealing with somebody who has the luck of having a caregiving network around them, but also empathetically knowing that they will have to take on the mantle of huge care and responsibility for that patient?
I think it goes back to what we said earlier with the adaptability with the person sitting in front of you. Part of empathy and empathic communication skills training is looking at the context of the patient. And it's part of history taking that is trained in medical schools, but how to use it is not always trained. I mean, it's trained in terms of like, okay, they can't take this medication because they can't, they wouldn't respond well, but also more, okay, do they have anyone to remind them, or is there someone that can help them get around the house? These are more human factors that you're not always trained to integrate. And so I think there are considerations and context that you may give to someone on their own that you wouldn't necessarily with someone with a very strong support network. You'd still give them the option, of course, but I think the invisible burden of caregivers is something that definitely needs more attention. There are some professionals that are very aware of this, and there are support resources for caregivers in some countries but not others. I think that goes back to the whole, it goes back to culture of healthcare and sort of assumed burdens depending on the sort of collectivist versus individual cultures, which is also something that plays a role in empathy expression and
well, I know that's something else that you've studied actually, and perhaps you see this as well in your work, Sarah. Cultural differences also bring their own taboos. They also bring their own modes of communication. So then a doctor or nurse or other medical staff member has to be trained in not just the medical part of life, but also the nuanced, highly nuanced communication differences when we have different cultures. So how do you train that up?
That's an area of constant learning, let's put it that way, particularly as globalization takes on a whole new course. And I think Luxembourg is honestly the perfect place to start looking at this because of the melting pot that we have here. Part of it is what we call cultural humility, which is being able to park your culture for a second and try to really fully understand where someone else might be coming from in terms of that perspective taking, and trying not to say mine is better than the other. Obviously, when you're in a culture dominated space, it's the natural thing to do. It's like, oh, well, this is what we all do. This is what we do on a daily basis. And so it can sometimes be a little bit harder to integrate someone else's schema of care into your approach. And so I think it's firstly an awareness point, and it's a sensitivity of like, wait, could this be coming from somewhere else? It's that extra reflexive question, I'd say. And I think that's part it is coming up more as medical education considers communication skills as a key clinical skill, which is great to see developing.
Well, it is. It's just it's quite strange that communication skills can lower burnout within the medical member themselves, and perhaps also lower the stress, because stress can be contagious sometimes. So if a doctor is feeling stressed and close to burnout, I'm quite sure some empathetic patients might be able to pick up on that stress and not feel able to ask that question of a doctor either. That might be their first, foremost, most important question. So again, if one can be lowered in one side of the conversation, it can go the other way too. When it comes to cultural differences in this great taboo topic of postpartum healthcare and incontinence, what do you see, Sarah?
Phew.
Or do you see anything at all? Because, I mean, Luxembourg is quite an open place to talk about, but even so.
Yeah, but it's still... Luxembourg is still very closed in a lot of, especially in that topic. Also, topic about, let's say, sex. There's, let's say, if we look at our Scandinavian neighbors to the north, where these topics are a lot more normalized, where there's a lot less taboo. Let's say also for women, for female sexuality. That is still kind of it's not, let's not say it's frowned upon, let's not say that Luxembourg is very uptight, but it's still those topics that are not talked about, and that are still, when you talk about them, it's like sex, and it's and that's something that you still see a lot, actually. In my experience, at least, and again, let's say I work a little bit more in a rural kind of place in Luxembourg. Maybe it's different if you work in the city. That's also very different. It also depends on if you, also something that we once talked about India with. Let's say with language barriers.
This is another cultural difference again.
Exactly.
Yeah, because people are trying to talk about not just something that, like, for them might be very difficult to talk about, but they're also trying to communicate it in another language, which is really, really hard.
Yeah.
So how do you deal with that?
I mean, luckily for me, a lot of my patients have been either Luxembourgish or German speaking, so that's not a topic for me. But and I hope that, and that's also something we've talked about. We've already talked a lot about that you as a patient, you have the right to find the caregiver, the doctor, the physio, whatever, who makes you feel comfortable, and where you say, maybe you also you say, look, the problem is worse than my language barrier. I don't care if I have to explain myself in French or German or whatever.
But that's a very important point that you've just said, because there will be people who, for very good reasons, will still have a lot of respect for doctors or surgeons, let's say, and they may not, particularly as you said, India, they're coming at a highly vulnerable time in their lives where their whole world has diminished into one topic, which is their health. And they may not know that they have the option to say, can I find somebody else? So how can a patient also develop their communication skills to feel strong enough and capable enough to stand up for themselves and say, I would like to see somebody else?
Positive reinforcement. It's always difficult to say. I try to tell it's also not the first thing you say when your patient comes into your practice, of course. But
you probably get a feel for it as well if you are working and aligned with somebody. Yes. And of course you're trained to align with as many people as possible, but sometimes that doesn't work out. And so perhaps, do you think it's incumbent upon the health professional to give that option to them also?
I think it's also very dependent on the specialty. In some cases, we don't always have the luxury of time. However, I think there is an empowerment element to it that comes through communication skills. It may not be as explicit as, by the way, you can go see someone else, because it can sound a bit like, okay, I don't know.
I don't want to deal with you anymore.
Exactly. When that's not necessarily the case, and you're trying to do the right thing. And as we know, there are many phrases about, in good intentions creating some less favourable outcomes. But I think it's a conversation to raise if you can see that a patient is becoming quite uncertain and there is the space, but you're welcome to get a second opinion. Or if you feel this is not clicking, this is something we do a lot in psychology, particularly because it's very relational. If you feel this isn't working, you're more than welcome to explore other options. In fact, it's really important in relational-based care, but I think that's less common in other areas because there is the assumption that it's primarily physical, which in many cases it can be, but there is a huge psychological element to at least the long-term management of certain conditions, which potentially needs to be integrated a bit more.
And do you have any figures or numbers on how good, positive communication can reduce pain?
I think it's quite hard to...
Perceived pain.
Yeah, perceived pain it's also very specialty dependent, so the numbers are not necessarily reflective of each setting. I don't have exact statistics on that necessarily, but for example, there was a study on sort of complaints about medical procedures, and at least 30% of those complaints were put down to communication faults. And so if that's something we can look at, sort of medical misdemeanors, we can probably see that in pain. My primary area is not pain at the moment. It's probably why I'm not so connected to the pain statistics at this time. But we do see at least better management of pain from a psychological perspective as well.
Yeah, that's what I meant. Really, just, can good communication help pain relief?
Yes, that it can definitely. There are studies that show quite strong correlations between those two.
Because pain is so connected to our psychology.
100%. And you often see that a lot of chronic pain patients are referred to psychological services for exactly this reason. I think a lot of it is also feeling the relief of feeling heard, of like, it's not all in my head. It is something I'm living and experiencing every day. And there is a connotation of being said, well, it's all psychological, can diminish that sense of experience every day, because there is still a taboo around the term psychosomatic or psychology, even though it is such an important element of how we live our day-to-day lives.
Now, another thing that you do, you co-chair the research division, and you actually chair the early career group of EACH, which is the International Association for Communication in Healthcare. And so year on year, how has this evolved?
It's a really fascinating question. I'm on the scientific committee for the conference we're planning later this year. And we're seeing a very interesting evolution of communication research and teaching, particularly with the advent of AI, because that is changing fundamentally how patients approach different healthcare interactions. And interestingly, there's a debate about whether or not patients are going to AI because they feel it's more empathetic, which is...
Well, I think there's a very high... I know, I don't know factually if it's correct, but hearsay-wise, I've heard a lot of people are using AI as a counsellor.
Yes, and that is unfortunately a bit problematic, because AI is usually, depending on how you program it, essentially made to please you. It wants you to keep interacting and wants you to keep going. And because of that, it's not going to push back at key moments where you need pushback from a trained professional. And that is where it can get quite dangerous, frankly, as we've seen in the news. We don't want to put it into extremes straight away. But there is a sense of being, all of the information you've given it, it is acknowledging it in a very kind way. And I think patients find solace in that. They feel really validated by an objective machine telling them, your problem is real, you are valuable as you are. And I think that's something we need to potentially be aware of. We do see that people are using AI in medical education training for communication skills as well, which raises another point of AI is fairly predictable. Patients are human and by nature less predictable. So
And now I just want to turn to both of you as individuals, because for you, Sarah, both of you are kind of starting out. You're in the beginning third of your career as building. And I know, Sarah, for you, it's very important to break this taboo around the conversation of incontinence and probably other conversations as well. So what do you hope? First of all, how did you even fall into this specific area? Because, you know, you trained as a physiotherapist over the whole body, and then you found yourself in this extremely niche region of the body. So how did that happen?
So I changed my workplace a few years ago, and I have a very lovely coworker, and we started this together in a house, Lebenshaus in Luxembourgish, and it's let's say a network of different kind of physiotherapy, coaching, and so on and so forth, and it's very targeted towards women. So of course, naturally, you kind of get into that thought of, okay, how can I also specialize then in that field? And then, of course, you see with social media, with everything, with news, with also being in a healthcare field, and being a woman in the 21st century, you see the struggles that we face. We have a lot less struggles than the women who came before us, thankfully, and thanks to those women.
Well, I mean, one of the main things is mostly we survive after childbirth. That
Yes.
wasn't a given not that long ago.
But there's also still so much that we don't know about the female body that's specific to us women, and so that's, let's say, in our battle for equality or equity, whatever you want to call it. Let's say we don't want to put ourselves above men necessarily, but to have the same possibilities and the same understanding of our body that our male counterparts have. This is one area where I say this is how I can help women. I am a healthcare professional, and this is the area that I want to go into, so that I can help women and empower women. Because if you can feel your own body, when you can feel your own pelvic floor and know what muscles and how you want to engage those muscles to, let's say, go play on the trampoline with your kids, go to a comedy show and not worry about peeing your pants because you're laughing, when you can feel every part of your body, and especially that part that is given so much life and pleasure as well. I think that's empowerment as well for women.
I think you've advertised it very, very well indeed. I think you have a good mission ahead of you. And also for you, because you firstly went into psychology, India, and then you found this gap there. And for some reason you fixed upon the communication in healthcare. How did you find that?
Well, it's a journey, as I will say. I think a lot of my life growing up as well, I've seen a lot of encounters with medicine with my family for various reasons and various health conditions in the family, and seen the impact of a, let's say, good or bad consult, and particularly for things in long-term care. The more chronic it is, the more you can see these gaps over time. And when I was in my psychology training and we were doing a lot of placements, we would go out to placements for skin conditions, for chronic pain, because we were right in that intersection between medicine and psychology. And the main thing that kept coming up time and time again is, I don't know if I want to go back because I'm just going to be made to feel like it's not real, or, you know, I don't even know what to do anymore. No one's telling me where to find information. I don't know what to do. Or a sense of powerlessness that felt rectifiable at the time. And so, well, you know, I'm sure it's not that bad. Naive 18-year-old kind of view. But then when you look into it a bit more, it's more than just a problem of not necessarily knowing where to find it, but then you sort of go down the rabbit hole and there's systemic issues. There's people who go into medicine to say really want to make a difference, and then the system puts them into a corner where they have no time for themselves, and they don't even know how to function, let alone practice. And it was just the complexity of humanity. We're just trying to help each other out, kind of thing. And
I love you use the word powerlessness there, and I can see it from both the patient side and also the medical professional side, because they might be in burnout, completely overwhelmed with the workload and lack of sleep and various things coming at them all of the time. And I was also listening, of course, to what you were saying, Sarah, and it may not feel like a big deal when it happens from time to time, one drop here, one drop there, but it's a build-up thing and it's moving in one direction unless somebody visits you, Sarah, or somebody like you. But again, it's the lack of control. Powerlessness, I mean, by definition, is a lack of control either over one's body or one's time or one's future when it comes to health. And you are literally focused on cancer research right now. And so anything that can give a person back power, and it seems that your research on communication, as simple as that sounds, can empower a person, whether that be the patient side or the caregiver side or the health professional side.
100%. I think it's that acknowledgement, firstly, that we're in a difficult situation here, and holding that, okay, I'm not crazy from both sides. Like I'm just human, and humans can help each other out. That kind of thing. That acknowledgement in and of itself can diffuse a lot of the uncertainty, because another party has recognized this is a tough situation, we're going to get through it, and there are people there at each step of the way, that I think makes a huge difference. And sometimes it's the simple answers that are the ones that make the cleanest solution. I mean, communication is the thing that we do every single day in care. It's used more frequently than drugs, for example, for treatment, yet it's the thing that we don't test in the same way.
It's also free.
It's also free, exactly.
Time might not be free. The time might be condensed into pockets of 7 minutes or such like, but it doesn't cost money or 15 years of research and then clinical trials, etc. Although there are different kind of trials going on here. So you also mentioned a word that I care about a lot, systemic processes. And so you are trying to think about how to bring back the best possible practices for communication skills right back into the education of the medical professionals. And I mean, this goes to you as well, Sarah, when it's, I know you studied physiotherapy here in Luxembourg at a wonderful sports system here, educational system here, LUNEX. I wonder how you were trained. Was this part of your training?
The pelvic floor?
Yeah.
It was, unfortunately, a half morning.
A half morning.
Of...
Isn't that interesting?
Yeah.
I mean, that in itself is very interesting.
That was also a few years ago, and I don't know how it is nowadays, but
well, I'm sure as a student you can return and write a course. But I mean, I'm only saying this not to call out any place at all. It's not their fault. The point is, it has been a taboo topic. It has been one that's just one of many topics somebody has to teach. But again, it's this systemicness. It's a taboo topic right the way back, and the education. So let's move to the education, because that's what you also focus on, India.
Yes, and I mean, from the education, it sets your norms. It sets what is expected of you in your practicing environment going forward. It also sets the role models that you should be looking to, who you should be modeling your practice off. And so practicing, for example, difficult conversations, breaking bad news in a space with other professionals, you can practice how is best to breach topics like this and learn from others' experience around you, and to bring in the importance of it right from the beginning, the importance of communication right from the beginning. It then becomes embedded into what you consider when you are working with a patient and to what is normal for you. And I think that makes a substantial difference. We see massive differences in those who have communication skills embedded in their training versus those who don't. Unfortunately, I don't have the statistics here, but even when you look at it from university to university and how they've integrated communication skills, we see that, for example, in Leicester, they now have an entire unit dedicated to empathic communication in healthcare.
In Leicester?
In Leicester, yeah. And they integrate that kind of communication skills and experiential learning from the beginning, literally practicing with people and seeing the difference it makes before your eyes whilst you're learning about other medical concepts. And so putting 2 and 2 together in real time with experience makes such a difference. Even at St Andrews, when they are integrating communication skills from year 1, from the first year, which I had the privilege of being a tutor on, and seeing the difference it makes from first year to 4th year.
And does it give the potential future doctor more confidence?
100%. You see a completely different demeanour walking into your, for example, they call them OSCEs, which is practice sort of physical exams when they're interacting with patients. The level of confidence from a first year to a 4th year that they've had consistent communication skills training is really quite remarkable.
And what is the difference between communication? Because some people are born able to talk a lot easily. And for a lot of people, it is much harder, even if they want to go into a practice which will involve a lot of communication with a client or a patient in whatever field or industry they happen to be in. Of course, medical, it's a certain form of communication already. It's very vulnerable communication, but it has to be clear and direct and scientific at times as well. How do you teach that type of communication?
That's where the research comes in a little bit, because we need to see what really works in the environment for the patients. Obviously, it's different in every context too, so every context sort of needs to know itself a bit more. We do know that empathy is trainable, the empathy that we're talking about here, so specifically clinical empathy. So it's a bit different to how I would show empathy for Sarah, for example, than I would with a patient one-on-one.
How give us an example.
So I like to put it more in the terms of you are able to separate where your emotions end and where the patient's begins, and use that as an orientation for your next choices of action. So that also, sorry to interrupt your trail of thought there, but by that, it also sounds like you're protecting the doctor who has to repeatedly give tough news to somebody else, or a psychologist or a nurse or whomever. I'm just using the word doctor. Because they also have to safeguard their own health. 100%, which is why we wanted to differentiate the term clinical, or in some places they call it therapeutic empathy, from day-to-day empathy, because it is regulated in a different way. And that's why training is so important, because it trains you to know where the boundaries are, but that you can still have empathy for the patient you're working with. There is still a human connection. It's just negotiated on different terms. And that is why the training is so important, to practice that skill. It's not your automatic empathy response is quite different to the communication skills you need to put in practice in reality to make sure you're able to work to the highest standard all the time.
And how can you train a clinician then to also talk empathically to that boundary line, their own boundary line, which I'm sure is different for everybody, of course, to encourage the patient to empathically reply or receive that information? This
is where it gets a bit tricky, because we're still trying to understand that bidirectional relationship. Patients are, as we all are, because we're all patients, we are products of our own information environment. We bring in our own experiences, our own interactions with social media, our tapestry of life, so to speak. We bring it into these consultations and have certain expectations. And so the expectation-reality gap can be quite difficult to navigate, and that is very diverse. And so it's quite difficult to have a one-size-fits-all of, okay, this is my boundary, how do I encourage it back? I think a lot of that is reflective speaking. So sort of, do you mind if I repeat back to you what I understood from your consultation? That's a line that's often trained in medical education. Something called the Calgary-Cambridge model. We won't go into theory, that's very boring for everyone. But it's essentially showing that you listened, like this is what I understood and took from it. What are you taking from this consultation? What do you understand? And that prompts a reflective response from the patient, of course.
On that, I mean, I have heard this before, and not just in medical settings, but I know a lot of difficult conversations require that. What is it that what have I just said? Yeah. Basically, have you actually heard what I actually said, those words out of my mouth? which actually, shockingly enough, is not the case. Do you happen to know how often it is not heard correctly?
Oh, I think
I think it's quite commonly
I think it's very common.
I think it's not heard correctly quite frequently, because I think, again, in a vulnerable setting, one's whole mind is condensed and you're in a state of fight or flight, fear mode. You're scared.
Tunnel vision. And that's completely normal, completely valid. And I think that's where initiatives like having these pamphlets or websites or direction is so important, because you're locked into one thing in particular, and kind of breaking out of that can take some time. You need that processing time, which is in itself part of empathy as well, I would say.
And then for you, Sarah, here in Luxembourg, I've never seen so many physiotherapists. Actually, to go to the kine, another word for physiotherapy, seems to be quite common here. How good is the relationship between, like, the triaging between your first primary caregiver, doctor, let's say, in a health centre, and them thinking about, okay, that could be fixed with, or even a dentist, and that could be fixed with some physiotherapy?
I think actually we're on a very good very good way here. From what I see, there's a lot of patients that come into practice because they have a problem, and either their general practitioner or a specialist or a dentist has said, look, I don't know exactly what this is. Before we start operating, go to the physio. They might be able to fix it. And sometimes, and now we can go into like the entire theory of osteopathy as well, where it's not just you have a knee problem, and it's not just like the knee, it's somewhere related in your lower back, or it's fascia, myofascial, actually. There are so many, and that's the thing where we as physiotherapists can think a little bit differently about the body, and maybe also give another input that has maybe been overlooked, or is just not in, let's say, in the field, and where the general practitioner or the specialist says, look, try going to the physiotherapist, and this might work, and you can actually help people a lot with that. And I think that's actually something where our healthcare system is really well set up. Also because we have a lot of physiotherapists, also because we aren't restricted by any financial limits, because the CNS is so well set up.
Which is ironic that the CNS can care for physiotherapy care, but not for psychological care.
Yes, I think part of that is, and whilst I'm still getting to know the system, I'm still quite fresh in Luxembourg, but I think a lot of it's because the regulation around psychologists is very different here. In other countries, psychotherapy is not regulated in the same way that it is here, and it is different forms of practice. And in other countries, there's lots of different specializations you can take, and the regulation is just not the same here. So the referral system can't function in the same way, which I think is, from what I've heard of the mental health need that is growing globally, I think it's something that we probably need to consider going forward as a.
I think they are also working a lot on, like
great.
they're currently going through the entire process of not just that psychiatrists are, let's say, reimbursed by the CNS, but also general psychologists and all that. So there we're also moving on to, because
it's beginning to change, and I think actually COVID kind of accelerated that conversation, because there were so many mental health needs through COVID, and not everybody could afford them, so there was a disconnect there as well. I'm thinking also, again, back to the blood test analogy here, how often, if ever, should a person go just for a check? Some people will never visit a therapist in their life, or an osteopath, for example. Should somebody just go and say, can I have a health check? Is my skeletal frame operating in the right way, or should I be doing anything?
I think generally, I would have said if you don't have any issues, don't go looking for issues, because that, again, that can rabbit hole, you know. However, I think nowadays, with our society, with the stress that we talked about before as well, that we all have, whether you are a doctor or a patient, or no matter what field you're working in, you have burnout, you have stress, you have bad nutrition, because also times, you know. So I think sooner or later someone will have headaches, you will have stomach aches, you will have something, we don't move enough, you will start feeling your knee pain, which is really just maybe do some squats, you know. Again, as cynical as this maybe sounds, and not to say that, again, every pain is real and every pain has a cause, and of course you can go to osteopathy or to physiotherapy and ask, look, I have a problem. You go to the doctor, you get the referral, of course. So I think, and again, we have the opportunity here, so we can use it. But again, if you say, I feel absolutely healthy and I have no problem at all, I think it's important to also just take a step back from the whole, let's say, catastrophizing of our bodies, of our health, and all that. And instead of going looking for something,
do the best with what we have.
Do the best with what we have, and actually celebrate if you're pain-free, because nice.
we take it for granted. We really take it for granted if we're doing okay. And we definitely should celebrate that. India, any final thoughts or comments to how we can improve our empathic communication skills?
Well, I think it's going back to context, and really understanding our context. So this is a bit of a research plug. If you want to take part in any research, please do so, because it helps us understand what the real issues are, so we can hopefully try support the solutions. But I think it's just that extra few seconds of reflection of, could this be coming from somewhere else, from both sides. This is a human rule rather than a one person, one side only rule.
Well, thank you, India, for making our medical profession more empathetic to us patients. And we will all be patients in the future in one form or another. That's almost given. As my friend yesterday said to me, I haven't yet met an immortal person. So we're all moving in one direction. Sarah, thank you so much also for breaking a taboo. And hopefully with your care, training will be more than just a half a day in physiotherapy schools from now on as well.
I think it is also, like, it has changed. And I think, of course, it also depends on whether you're going more into the sports physiotherapy, where, the syllabus is more focused on everything that's orthopedic.
The body is a large
large
set of things that can require a physiotherapist or other forms of empathetic communication skills later on. Thank you so much for listening. If you have any thoughts, do get in touch. You know where to find me, and also everything to do with RTL Today, RTL Play, Apple Podcasts, Spotify, Today Radio. Plenty of ways to get in touch with us, and have a wonderful week ahead.